Hello, everyone. We're going to get started now. So today we're hearing from Dr. Pam Lutze. She's a full professor here in the Division of Epidemiology and Community Health, and I'm going to introduce her a little bit. Pam Lutze is an epidemiologist whose mission is to identify potentially changeable factors that influence risk of cardiovascular disease and other conditions. Areas of particular interest include nutritional biomarkers such as serum magnesium, sleep disordered breathing, venous thromboembolism, and the identification of risk factors for dementia. Much of her research calls on two long-term studies, which are ERIC and MESA. She's also using large administrative data sources such as MarketScan and Medicare to compare the effectiveness of new versus established treatment strategies for venous thromboembolism and atrial fibrillation. Pam got her MPH and PhD in epidemiology here at the University of Minnesota, and she's a fantastic mentor. And so we would now like to present a special gift to Pam for coming. Oh, there you go.
Feels like we should wait till after the talk to give the and I want to mention Sam Sheet, who is here and will be presenting for 10 minutes in the middle as well, giving a different example of a pharmacoepi approach. So I was trained as a classical epidemiologist, and that's how most of you know me. These are words that I identify strongly with professionally. Had you asked me a decade ago, would I be doing work and be excited about work in pharmacoepidemiology? I probably would have kind of laughed at you and said, no, I don't think so. That's not for me. But over the course of the past decade, I found to really identify with some of these words as well. And in fact, I think the two approaches really can inform and complement each other. And so honestly, it's been fun. And I'm excited to share a little bit about this with you today. So I'll begin with an introduction, and then we'll have a few applications of pharmacoepi, and then we'll talk about opportunities if this is an area that you might be interested in. So to begin, what is pharmacoepidemiology? Well, it's a bridge science that spans the disciplines of clinical pharmacology, which is studying the use of drugs in humans, and also epidemiology. It draws methods from both. And so in terms of a formal definition, the International Society of Pharmacoepidemiology defines it as the science that applies epidemiologic approaches to studying the use, effectiveness, value, and safety of pharmaceuticals. And a point that I want to make from the outset is that it's not just drugs. These methods applied to devices and biologics are also fall under the pharmacoepi realm. So when we think about the phases of drug development, most of us, what we're most familiar with is phase 3. These are the trials that are published in the New England Journal and JAMA and, move a new drug forward to FDA regulation. Where pharmacoepidemiology, though it has a role across the spectrum, where it has the greatest impact is in phase 4, post-approval. And this relates to studying the safety, and effectiveness in populations. So this should take you all back to Epi 1. I actually stole this from my slides from when I taught Epi 1. When we think about causation, randomized controlled trials are at the top of the triangle. They provide the strongest evidence. That doesn't change, and that's an important context to keep in mind as we go through this presentation. So though randomized controlled trials are our most rigorous design, they're not perfect. So here I show a pragmatic explanatory continuum indicator summary tool figure for a prospective randomized double-blind trial. And so what this figure does is it, on a variety of trial characteristics, such as eligibility, recruitment, and setting, ranks the study in terms of how pragmatic it is. And so for trials, often eligibility is really restricted. They want people in a certain age range with, a certain stage of the disease process without certain comorbidities. So it's a kind of a selected sample. It doesn't represent everyone with a disease of interest who may benefit from the drug. Similarly, recruitment in trials, very rigorous and specific setting. Trials are often done in academic settings or in tertiary care centers. What about the broader population? Does the drug have the same impact when implemented in a different setting? Likewise, thinking about deliverability and adherence. In a trial, there's a lot of effort made to make sure that the drugs are delivered in a rigorous and standard manner. And the real world may be different. So if we look at this same figure for a theoretical retrospective observational study, at least in theory, you're much higher in terms of a pragmatic approach in regards to eligibility. You can include everyone with data in your sample. Also recruitment setting, you can include some of the data sets we're going to talk about span the entire United States. And so you have just, everyone who's getting the drug can be represented, at least in theory. And then of course, delivery and adherence. How do people actually take the drug in real life? So thinking about potential contributions of pharmacoepi, starting with, it can supplement information from pre-marketing randomized controlled trials. So from our phase 3 RCTs. First of all, pharmacoepi studies often are much larger and so have higher precision. Secondly, as I alluded, they can include patients who did not participate in the pre-marketing RCTs, such as children, pregnant people, and older adults are often excluded. Yet, especially older adults take a lot of pharmaceuticals. You can also evaluate whether a drug is modified by other drugs or illnesses, or whether this should say a drug, impact is modified by other drugs or illnesses. This is addressing people who are excluded from the trials. For instance, those, say, with low kidney function that process drugs differently. And you can do head-to-head comparison of drugs used for the same indication. And I'll give an example of this coming up. Often when a drug comes out, it's prepared, there may be multiple new drugs that come out for a condition at the same time. And they're compared either to placebo or to standard of care. So if you have multiple new drugs, what is the best? The pharmaceutical companies don't have a lot of incentive, at least initially, to ask those questions. It can also provide new information not available in pre-marketing RCTs. So patterns of utilization. Is it actually being used, and by who? You can also discover previously undetected adverse and beneficial effects. So these can be things like uncommon effects. Maybe if someone takes, trials last, 1 to 5 years. 5 years is a nice range, maybe 10. But with trials, what happens if someone takes the drug over a longer period? Or, what are delayed effects? And also uncommon effects. So, trials have a set sample size. I'm thinking, the bigger cardiovascular trials for people with a cardiovascular condition, maybe 5,000 people. Well, what about rare serious effects? The trials are underpowered for those. And it can also provide information on effects of off-label use. The reality is that there are a lot of drugs that are being used for in a lot of settings where the person doesn't have the official indication, but the drugs are being used anyway. And it can provide information about the economic implications of drug use. And then general contributions in regard to reassurances about whether a drug is safe and, helping from an FDA and regulatory perspective, fulfilling ethical and legal obligations. And the US FDA values pharmacoepidemiology for clinical decision-making. In 2018, the FDA released a real-world evidence, RWE framework, supporting the use of real-world evidence in their decision making. And I'm going to show this right now because we'll circle back to these definitions. So the FDA defines real world data as data related to patient health status and or the delivery of health care routinely collected from a variety of sources. So these include, electronic health records, medical claims. You are in these data sets, even if you don't know it. This is data and often billing data collected as part of standard care. And then evidence generated from real world data is real world evidence. So to take a moment and talk about real world or health claims data, since some of you have experience with those data sources, many of you probably don't. So what are health claims data? Well, if you have a medical encounter, there will be, at a minimum, billing data generated related to the physician, the facility, the pharmacy, if you get a prescription. And that information will go to a health insurer. The health insurer then obviously compiles the data, and it can be available for research in some instances and with appropriate approvals. So in terms of what is in health claims data, it's a record of billing for all services provided by the insurer. So prescription, inpatient, outpatient, ER and diagnostic services. And it also has insurance enrollment information, things like age and sex. There's, usually you have continuous information on enrollment, or at least monthly, so you have a data flake, so you have a denominator, which is really important, and dependent status. And so there are times when using health claims data makes a lot of sense. So for instance, when it is not possible or feasible to collect the data. For example, if you need a really large sample size, if you're working with a rare disease, doing a study can be really, really hard. Also, if there's a long observation between an exposure and outcome, sometimes you can use administrative data to address important research questions. Historical events, sometimes you can, I'm thinking about, policy work, you can look at the impact of a historical event or policy on health outcomes. And, sometimes there may be ethical considerations that prohibit you from doing a new study. And it also can be great while waiting. These data can also be used when waiting to collect data is not ideal. So if we have new drugs coming on the market, do we want to do another 5 or 10-year study? Or do we want to get answers sooner about whether they're being effective and if there are some side effects that are surprises? And it also can be useful when effectiveness is more important than efficacy. If you have the best drug in the world, but it causes horrific side effects, are people really going to take it? And so what is the actual true effect of the drug in the population? Additional benefits, there are existing data. And so there's potential to be really efficient in the sorts of studies that you address. There's low or no data collection burden on patients and providers. And as someone who spends a lot of time with primary data collection, it's really kind of refreshing to think of a new question and just be able to go into a data set and try to address it. Also, these data are often generalizable across large geographic areas and diverse patient populations. And also, there are generalizability benefits due to passive observation. People who enroll and stay in our studies are different. They tend to be healthier. They tend to be more compliant. So what happens in the real world? Now, what is not in health claims data is equally as important to understand. So for instance, what service is actually provided? The truth of the matter is that there's sometimes discrepancies between what is billed for and the service actually provided. There can be sometimes financial incentives to bill a certain way. Also, for prescriptions, whether the medicine was actually taken. You know, you may have pills in your cupboards or, you know, took care of them safely, that you didn't actually take. The result of a diagnostic procedure. Often with these data, we can know that a test was conducted, but we don't know what the result was. So like if we do a test, HbA1c among a diabetic person, we can know that they had a test, but we don't know if they were in control or out of control and how that may be related to medication changes or not. We also often lack detailed demographic information on things that are really important, such as race, education, and income. Likewise, behavioral information, such as smoking, physical activity, and diet, is basically never present in these data sources, at least the ones I've encountered. And any service used outside the billing process, we wouldn't know about. So Sam's going to present from the Fairview data. If someone gets care outside of Fairview, that's going to be missing from his data set analysis. And also mortality that does not result in a billable event is missed in some of these data sources. And of course, that's a really important endpoint. So design and analysis. One thing I've really appreciated about the pharmacoepi field is that I feel like it's really grounded in the counterfactual and the target trial emulation concept. And so, you know, emulating the target trial is a core tool of causal inferences using real-world data. And so for each causal effect of interest, we should imagine what our trial, you know, would look like if we could do it. And that's what we should try to emulate in our analytic approach. And in doing this, you know, there may need to be some tailoring related to the data that are available. And sometimes, you know, some aspects of this are fairly easy to do, such as, you know, eligibility criteria. Usually, you know, some types are fairly easy. Others require more work. Defining the start of follow-up, you would think that would be simple. It is not. And so some of you may be familiar with Hernan's framework. So just to walk through each of these quickly. Can you see my mouse? Yes, okay. So, you know, eligibility criteria, we hear about who would be included in the study. In the pharmacoepidemiology context, typically we usually use broad eligibility criteria because we want our results to be generalizable to a larger population. So we may consider all patients to use a certain drug or else a specific patient subgroup. Treatment strategies. What interventions will eligible persons receive? Well, in pharmacoepidemiology, typically it's a drug, device, or biologic. And whenever possible, we should use an active comparator. You know, when thinking about a trial has a drug and a placebo, or a drug and an active comparator. So if we go at these data with a drug and nothing, we're going to get ourselves in trouble in terms of bias. Catherine Giorgio finished her MPH in Epi with us last year, and she's getting a biostat MS. Her biostat MS project is actually working around methods for what to do when you don't have an active comparator. So that more to come on that project. It's a really important question. So treatment assignment. How will eligible persons be assigned to interventions? You know, so that's determined by the care team. That's not randomized. And this is where, you know, we can never know the intent for why a physician prescribed one drug versus the other in the context of these administrative data. And so this is where, you know, these data fall short of a randomized controlled trial. For outcomes, we typically use, you know, we compare as you would expect outcomes in the intervention versus control group. And they're often based on ICD codes. And I'll talk a little bit more about this classification there coming up too. Follow-up time, you know, usually it's from the prescription date until the event of interest, death, loss to follow-up, or administrative censoring, as you would typically do with a prospective analysis. In terms of what we're estimating, typically, and there's a pretty robust methods of literature saying that intent to treat is the best approach. So when you do this work, someone's thinking back to Epi 1, once randomized, always analyzed. So here, once someone is assigned a drug, if it's their first drug out of the gate for the condition, you keep them on that drug for the duration of follow-up. And the reason is because if you don't, there's potential for bias, because if someone switches drugs, well, why did they switch drugs? Was it not working? Did they have side effects? There's just a lot of unknowns. And so back to the core concept of targeting of emulating the target trial, intent to treat is what the methods literature strongly supports. And then of course that follows through in the analysis. So threats to validity. Confounding, of course, is a huge threat because as we've discussed, treatment assignment is not random. Also, key confounders aren't available. And so to address this confounding that we know is present, we attempt to minimize it using kind of the usual suspects. So restriction, of course. Matching is actually used extensively in the pharmacoepidemiology field, which is a little different from classical epidemiology, where I think maybe I've matched once in my classical epi studies, and almost all of my pharmacoepi paperwork uses matching. And I'll give an example of that coming up too. Also, propensity scores are often used, either kind of a typical propensity score, I don't know exactly what to call it, or else high dimensional, which takes advantage of all the data in the data set. I will say though that the high dimensional haven't been that fruitful beyond the regular propensity scores, and they're a lot of work. Inverse probability weighting is another option, and Sam will give an example there. And then instrumental variables. So threats to validity then, selection bias is huge. When do you start follow-up is a really big question, and there's a lot of potential for immortal time bias. If you look at all the immortal time bias papers, not all of them, but many of them use pharmacoepi as examples. There's a reason. Information bias. We only have access to the prescription that was filled, or in Fairview, the prescription written. And so we don't know whether the drug was actually taken. ICD codes, they're imperfect. Sensitivity and specificity can be poor. And then of course, we always need to keep chance in mind. So these data sets tend to be larger. So hopefully chance is less of a concern. So some applications. Venous thromboembolism is one of the things I study. People can have blood clots. Often they occur in the lower extremities, in the veins, and they can then travel through the heart and into the lungs, where they cause a pulmonary infarction or lung tissue death. It affects about 1 million Americans per year, and 1/3 of cases are provoked by cancer. So the treatment is oral anticoagulant therapy. And with oral anticoagulants, you're affecting how someone bleeds. And so you need to balance the risk of a recurrent clot versus the risk of bleeding. And both are very important outcomes. Historically, warfarin was the only option really for treatment. However, in 2012, 4 new direct oral anticoagulants, well, 2012 and shortly thereafter, there were 4 new direct oral anticoagulants introduced. And these were approved based on non-inferiority trials. And so they were considered equivalent to warfarin. Now, warfarin has some issues like food interactions, drug interactions. It's not a great drug to be on long-term. And so there was some excitement that these could improve patient quality of life and possibly even be better in terms of bleeding and recurrence risk. So we had some questions. So were the trials that led to the approval representative of the target population? The trials, they were one drug versus warfarin, so there were no head-to-head comparisons. And the trials were not powered for rare outcomes or evaluating risk in patient subgroups. And in particular, cancer-associated VTE as I said, it's a third of all VTE cases. These people have a different bleeding profile, and they were not included in the randomized clinical trials that led to the FDA approval. However, we were pretty sure that off-label use was happening. So to test these questions, one of the databases we used is the MarketScan commercial and Medicare supplemental databases. These are individual level de-identified HIPAA compliant healthcare databases, and they contain, the data elements we've described previously. And so for the initial grant, I got the data. Since then, Minnesota, I'm elated to say, now has a site license. We're on our second renewal of the site license. Joel Farley from Pharmacy spearheaded the effort. I was also deeply involved. We actually crowdsourced across campus to have money for this resource. So thinking about VTE treatment, we included in our MarketScan analysis, we concluded suspected VTE cases only for the years 2011 through 2017. I'll also show some data that go a bit later. The first step was to figure out, well, how do you define VTE, our exposures and outcomes in this data set? And so, we found a validation study, positive predictive value of 91%, which is pretty good. Not perfect, but good. Warfarin use, there's billing. It has a positive predictive value of 99% in validation studies. DOACs weren't yet validated, but given that it has the same billing process, we thought the validity was probably pretty good. Hospitalized bleeding had a positive predictive value of 90%. And we only included inpatient bleeding events because outpatient had much lower sensitivity and specificity and didn't trust it. And then, of course, we had to define comorbidities too. So we started with almost 500,000 potential individuals with VTE. We really wanted true cases, and so whittled our sample down to 170,000. One of the first things we wanted to do was to understand, just descriptively, are these drugs actually being used, and how has usage changed across time? So on our y-axis, we have prevalence, and on our x-axis, we have time. And so you'll see in quarter 1 of 2012, warfarin was being used almost exclusively. By 2017, quarter 4, it's less than 20%. With rivaroxaban, when it came on the market, it took market share, and then apixaban as well. And apixaban has actually continued to get greater market share as time has gone on. So this was useful just from a descriptive standpoint, and actually has been cited quite a bit. Next, though, of course, we're interested in outcomes. And so from our 173,000, we matched on age with a 3-year window, sex, enrollment date. And enrollment date was important because that impacts how much covariate information we have on the population. And also kind of the drugs coming on the market at different times. It was really important, enrollment date. Likewise, anticoagulant initiation date within 90 days, just knowing that early adopters tend to be different than once the drug is more established. And so in this analytic sample, we had 83,000. We restricted our follow-up to 6 months, and this was trying to emulate a target trial. The trials are published with a primary endpoint at 6 months follow-up, so we did the same. We also matched and then did proportional hazards regression, as you would expect. We used a propensity score based on information that was collected prior to the VTE event. And then we did sensitivity analyses, adjusting for high dimensional propensity scores too. And so what we found was that in the head-to-head comparison of apixaban versus rivaroxaban, and this is something that the drug companies hadn't done, apixaban was better in terms of bleeding risk with a hazard ratio of 0.58. So quite robustly better. Looking at apixaban versus warfarin, it was also better with a hazard ratio of 0.68. And then rivaroxaban versus warfarin was, a hazard ratio of 0.98. So they were equivalent in this analysis. We also, and I'm not going to spend time on this slide, but we're able to look at straight up by sex, age, category, and chronic kidney disease status, which the trials were not powered for subgroups and didn't include many CKD patients. Additionally, as I mentioned, we had a specific interest in cancer-associated VTE. And so of our sample, 26,000 individuals had active cancer and VTE. And there were 1,200 bleeding events. So these were people, those who were on the DOACs were taking them off label. And what we found here was a hazard ratio of 0.88. That was not statistically significant. So it was in the direction of DOACs being beneficial in terms of bleeding risk, though the confidence interval was wide. But here, just to be able to say that DOACs are safe in the context of cancer was important because they didn't have FDA approval for this indication, though they were being used. Limitations of this work. So there are many potential sources of bias. There can be exposure and outcome misclassification. So if there's misclassification, for the most part, it is likely non-differential and likely with bias results toward the null. There's also uncontrolled confounding. We don't have information on lifestyle factors or physiologic factors like BMI or over-the-counter meds. And of course, there could be residual confounding too. And we did have limited power for some comparisons. But hopefully we still learned something useful. And now Sam Shi is going to give us a brief interlude to talk about using the target trial framework to compare the effect of high and low opioid dosing strategies at post-surgical discharge on newly developed opioid use disorder. And so Sam is a PharmD. He's also a PhD candidate in the Department of Pharmaceutical Care and Health Systems. And at the recent ICPE, the Pharmacoepidemiology conference, he won the award for the most highly rated student abstract. So.
Thank you, Pam, for the introduction. Can you all hear me? Thank you. So yeah, my name is Sam Shi. It's really great honor to present my research work today at epidemiology seminars. So I have nothing to disclose. So just imagine that you were a surgeon and you have a patient just had a surgery. Now you want to discharge them with opioids. You start to wonder whether the dose, the high versus low, will cause any harm to patients. And then just some background information about the dosing. So this is commonly used, the MME we use to determine the opioids dosing. So it's basically the equivalent of standardized dosing. You convert any kind of opioids to morphine. And there are two types of MME. One is total MME. So you can see that is to do some calculation based on the entire prescriptions. Another we will be, you probably will be familiar with is the daily MME or the average MME. And this is more used in the chronic settings. So in acute setting or post-acute setting, like post-surgical, the daily MME is not a good fit. And you can see like different opioids has different MME, even though they have different strength or quantities. So that's why there's some issues in post-surgical opioid prescribing and discharge. So we all know that opioid overprescribing is still an issue in the US, especially at the post-surgical settings. And the reason is there's wide variations. Even for the same surgery types, you see the surgeon that prescribe a wide variation of dose. And there's no consensus about how much to prescribe for those surgical at discharge. And there's no randomized clinical trial to tell us that what's the best strategies. And that's why we motivate us to conduct this research. And we think that the post-surgical opioid prescribing may be associated with a new risk of opioid use disorder. So this is what we've done, like using a target trial, because there's no randomized clinical trial. So we're thinking that perhaps we can emulate one with an existing observational data. So our research question is, with surgical patients, they showed high total MME associated with a higher risk of new opioid disorder in 2 years compared to the patient discharged with low total MME. And the study design is a target trials approach. I think Pam already mentioned about target triangulation. And these are some tutorials, resource, if you are interested to learn more about what is target trial and how to conduct those. Those are good resource and information. And I include the reference at the end. And here are some examples about the applications, how you use target trial in different fields. And as we know that there's currently this haven't been target trial being used in opioid use, especially in post-surgical settings. So this is the trial protocol of our studies. So there are some key protocol components, just like we are doing a randomized clinical trials. And then you use your existing data. For us, we are using the EHR data. So then you emulate based on the hypothetical trial you imagine. So these are some criteria, eligibility, treatment strategies, and how you assign patient. But because you are using the observational data, you're not really able to assign patients. So you use some other techniques to emulate that randomization process, such as propensity score weightings, and then our follow-up outcome. So those key components, just like Pam mentioned. Our methodology, so this is more deep into our methodology. So basically follow the PICOs. The population is opioid naive adults who had undergone their first either major or minor surgery, the Fairview, and then discharged with an opioid. And the intervention is high MME, and that threshold is 200 based on Minnesota Department of Health recommendations. Comparison is low MME, less or equal to 200, and the outcome is a new developed opioid use disorder at 2 years. Our inclusion criteria is adult populations greater than 18 years old, and the first surgery with opioid prescribed on discharge, and then they has to at least one outpatient visit with primary care provider within 2 years prior to the index surgery, and others. Exclusion criteria, we exclude the prior surgeries, prior opioid use, or if they have any existing opioid disorders, and then other covariates, baseline, age, sex, and other comorbidities or surgical factors. And statistic, we use a standardized log binomial regression model because we want to estimate the risk. We use inverse probability weighting, and we assign a stabilized weight just to protect that from inflation of some extreme or outlier of propensity score. And we also conducted several sensitivity analysis to examine the robustness of our results. And our data source is EHR data from MHealth Fairview. That's from 2010 to 2019. So for those who are not familiar with EHR data, I have the QR code here. You can scan that. It's basically you collect all the information from all those clinic and hospital from MHealth Fairview, and they have many different, we call that as relational tables. So those information, it has a bunch of information. And the beauty for the EHR data, it has really rich information, especially for clinical information. And this is how we like extract information from EHR data. So first, from the database that is from MHealth Fairview, and then based on our protocol and our IRB, we request the data to the BPIC team at the University of Minnesota. And they provide those relational tables, such as patient, service, medication, diagnosis tables, or procedure tables. But those are not yet for study or research. So what we still have to do is, based on your protocol, and then you create or generate variables for your own research. So I would say usually this part is the most time-consuming part. It took me a while to think what covariates I should generate and how do I do that. So I use the SQL language to extract those information. And then after I have all those variables, then we enter the stage of data analysis. And I use data to analyze my data. So these are the result of our result, the flow chart subject population. So at first we identified 179,000 patients. They had the first surgery and they discharged with the opioids. And then after applying all those exclusion criteria, at the end, we have about very similar numbers of high MME versus low MME based on the opioids they discharge. And this is the covariant balance because we are not doing a randomized controlled trial, but we really want to emulate that part. So how to evaluate the balance between those high versus low? You use the balance plot by propensity score, and that is based on all those covariates. So you can see before we apply the inverse probability treatment weighting, in the row, the control group is the low MME group, and the treatment group is the high MME group. So they are not quite balanced. After weighting, you see the figures are pretty matched to each others. And this is the result of our the outcomes. So primary outcome, you see compare the high MME versus low MME. The relative risk for 2-year opioid disorder is about 1.73. And then for other secondary outcomes, most are significant. The 90 days ED visit, short-term all-cause mortalities, or long-term opioid use, those are significant in the high MME group. Others, like long-term, like 1-year all-cause mortality, or EGFR, the kidney dysfunction after surgical is not significant between those two groups. We also conducted sensitivity analysis just to try to examine the treatment effect based on different threshold. Beside the 200, we also choose the 135, 300, or 450, trying to see if there's any dose response for the main outcomes, 2 years OUD. And as you can see that as the threshold increase, the high MME is the effect for the 2 years OUD, the new developed opioid disorder increased. And it seems there's a dose response rate. Another way to examine the sensitivity analysis is we try to examine the outcomes at different follow-up. For example, like 1 year, so that is the day 0 to first year, or 2 years OUD, so that is the day 0 to 2 years after the discharge, or 3 years. And you can see that the high MME group, like greater than 200, they all have a higher risk of getting a new opioid disorder compared to low MME group. So this is to summarize our finding. Compared to low total MME group, the high MME group, they have a significantly higher risk of new OUD at 2 years. And we also seen that those high MME group also have higher risk of ED visit, long-term opioid use, or short-term all-cause mortality. But we didn't see the high MME group is associated with the short-term kidney dysfunction after surgery. So the take-home message is initial opioid dose does matter, less is more, and target trial framework is feasible to support clinical decision-making in opioid dosing strategy and post-surgical discharge. Here is my reference, and I would like to acknowledge my team, like my advisor, Professor Wendy St. Peter, and all other co-authors. I also like to thank Susan. I saw she's here because I learned a lot from the advanced epidemiology course at 83, 40, 0, 41, 42, those. I think that has really helped me to think through how I do this research, especially the pharmacoepidemiology. And I'm happy to take questions later. Thank you.
So thank you. We'll do Sam questions from Sam at the very end. So thank you, Sam, for presenting that. I thought it was just a fantastic example of a really important contemporary issue with potential policy implications and using the Fairview data, which is a different data source than I use. And I'm going to go quickly through some of these slides, given like I want to make sure we have some time for questions, but I'll say, you know, several PhD students have used this work, and we've looked at off-target effects, we've looked at rare diseases, subgroups not included or minimally represented in RCTs, head-to-head comparisons unlikely to be done by the pharmaceutical industry, you know, unethical things that are unethical or impractical to do in an RCT, and off-label drug use as well. So, you know, I in the beginning, I talked about potential contributions, and these are ones that we've directly hit on. So opportunities. I guess the question is, can you do this within your research area? And so kind of as a challenge to myself, I tried to think of like other people in research areas in the division, and would there be opportunities for them using pharmacoepidemiology data? So, you know, something like eating disorders, you could look at trends in diagnoses or trends in treatment approaches, novel anti-obesity therapies. You know, these are huge right now. There's a ton of questions that could be addressed with these data. And actually, so I made this slide earlier in the week. Yesterday, published ahead of print in JAMA, as a research letter, was this paper on GLP-1s, which are some of the new anti-obesity drugs, where they looked at 2 of them compared to a control in relation to off-target effects. So gastrointestinal adverse effects for pancreatitis, hazard ratio of 9, bowel obstruction 4.2. Of course, these confidence intervals, you could drive a bus through them, but they're still interesting, and we need to look at absolute effects too. But so this is the type of thing you can do with these data. Also, Emily Groen, a recent PhD student, worked with Shalini. They looked at gonorrhea in the MarketScan database. They found 32,000 people, women had it, of 5,000 screened. And they found that gonorrhea was associated with higher risk of pelvic inflammatory disease, ectopic pregnancy, and tubal factor infertility. So another diverse example. So what data are available? And I'm choosing to highlight 3 here. So MarketScan, and this has about 53 million people per year. And so that's, you know, across time, you may have, people will be in the sample across time. So it's easiest just to think about it in terms of a 1-year slice is 43 million. Medicare, 20% sample. So this is, we have access to data from a random 20% of everyone enrolled in Medicare throughout the entire US. So that's a very powerful data source, and almost everyone over 65 is enrolled in Medicare. So pretty fantastic data source. 11 million people per year. And then for Fairview, I was only able to get numbers for all years. So across time, Fairview has a total of 4.5 million unique individuals. Thinking about age ranges, MarketScan, mHealth Fairview, they have the spectrum. Medicare is 65 plus. Samples, you know, MarketScan includes people who are publicly insured. So depending on your research question, it may not be a good data source for you. Medicare is nationwide and I think truly representative. And then Fairview data include people who came to the Fairview clinics. Race ethnicity is unknown in MarketScan. It's just not present. It's self-reported in Medicare and mHealth Fairview. Mortality is not available in MarketScan, and this has been the number of revised and resubmits responses I've written about this, you have no idea. But anyway, it is available in Medicare and mHealth Fairview. All three data sets, we have data starting about 2011, 2013 or therefore. In terms of requirements and availability, so for the MarketScan data, we presently have a 3-year site license. We renewed it fairly recently. It's something that we really hope to continue. The Medicare 20% sample data require a formal data use agreement with CMS. It's work. Like it probably takes about 6 months from when you start until you actually have approval to use the data. And you need a DUA for every different question you ask. I mean, you can ask questions broadly, but it's a lot of work. But they're very valuable data. And then there is an IRB approval process with mHealth Fairview. And in terms of cost, there may be some costs, but they're not overly prohibitive, I don't think. And students have used Holly Awards in order to be able to access some of these data. So support. I actually hold a weekly pharmacoepi team meeting. And I don't know, I think we have a lot of fun, honestly, and hopefully do some good science. We also have example code to help get people started. And we have a repository of methods papers and actually revise and resubmit responses. So like how to handle death, what to say when you don't have death in MarketScan. The social and administrative pharmacy group is also doing excellent work, as you've seen. And they in particular have a seminar coming up by Julie Lockenberger, who does incredible work on pragmatic RCTs in healthcare systems. And I just threw this strong textbook on here too, because it's really, I think, the text in the field. However, there are practical challenges. The data are messy and can be difficult to work with. Long data sets, so multiple rows per person rather than wide, like most of us are used to. The initial steps to creating the analytic data set, that's 80 or 90% of your work. It's very intensive. Follow-up time is tricky. If people change enrollment, you lose them. What do you do about that? And there can be breaks in enrollment. You need to carefully define all variables. I mentioned the sensitivity and specificity of in relation to my VTE project. And so, often we have these huge Excel files that have crosswalks for all the codes to try to figure out what makes sense if there is not a validation study available. So the data management and manipulation is intensive. And not every research question is well suited to these data, to be frank. So my first PhD student was Rachel Ogilvie, and she was interested in looking at sleep apnea and cardiovascular disease among atrial fibrillation patients and doing this in the MarketScan data. Okay, let's go. So, and this is a cautionary tale, by the way. So we didn't fully appreciate when we embarked on this that 85% of OSA is undiagnosed. And that misclassification is differential because people who are wealthier and who have better access to healthcare are more likely to have their OSA diagnosed. And so when she ran the initial results, OSA was associated with lower CVD risk and very strongly with a hazard ratio of 0.4. This is not what you want to see in a dissertation paper. So fortunately, Rich McElhost was heavily involved in this. We did quantitative bias analysis. We ended up publishing it in epidemiology with a subtitle, The Role of Measurement Error from Administrative Data. We learned a lot. There are questions, though, that these data, you just shouldn't go down the path. Final reminder, RCT is best in terms of causal inference. And, there are numerous FECH grads doing pharmacoepi work. And actually, Brendan Diesner and Liz Bell are both here. You'll see them in the picture, too. This picture was taken at the recent International Conference on Pharmacoepi meeting. And one thing I want to point out is that these people hold an array of positions from academic, non-academic to you know, Canvas is this really hybrid, including both academic and non-academic aspects. And so, thank you for letting me share with you. I hope you've maybe learned a little bit more about pharmacoepi and seen how these fields can be complementary. Also want to thank my funding and collaborators. And I do want to mention that clinical colleagues are so critical to this work. I cannot begin to convey how important they are because, you know, I'm not seeing patients in the clinic. Just the sorts of questions they ask and the perspective they have is invaluable. And with that, we'll open it up to questions for either Sam or me.
For Sam or for any work with EHR data without insurance data, how do you handle you know, after you randomize when they're discharged with high and low MME, and how do you handle loss to follow-up or death during your follow-up time period? If they don't have a clinic visit in the health system that you can see, do you consider them loss to follow-up and take them out of the risk split?
Yeah, thank you for the question. That's a really good question because I have discussed that with my advisor. Because we don't have like continuous enrollment as we use claim data. So what we do is that we try to fix that by adding another criteria. They must have seen like at least one outpatient visit in Fairview before the index day of surgery. So we're trying to use that so our population. We hope that we can find a population that they have in continuous use by having at least one primary care visit before the surgeries. And for the flu shot follow-up, I think it also depends on what kind of estimate you want to use. So if you are using the cost regression, so you might have to think about like sensory other issues. And in our examples, we are using we are estimated risk. So we're trying to use different years, kind of address that issue like indirectly. Yes.
Sam, I have another question for you. Did you look at follow-up opioid prescriptions after that initial? So your randomization to 200 MMEs above the low was an initial prescription. Did you look to see if they had any additional prescriptions over time?
We did. So that is actually one of the secondary outcome persistent reviews. And we follow up those patients up to actually 3 years after. And we look into those medications, prescribing information like quarterly. And we have seen that for those high MME group, they have been consistently have higher risk of refilling opioids in dental Fairviews. Yes.
So we are almost at the top of the hour. I just want to say thank you so much to Pam and Sam. If you are a PhD student, Pam can hang around for a few more minutes, I think until 11:30 in the Commons after all of this wraps up. And the last question is going to go to David.
Thanks. And I think that this is for Pam. One of the most enduring and rebuttaling observations in our cohort studies is that blood pressure medication is related to adverse events in direct contradiction to the randomized trials. I wonder what the status is of pharmacoepidemiologic studies or any thought of understanding why that happens.
Oh, what specific adverse events are you talking about?
Cardiovascular disease, death, things like that.
I'd have to think about that one carefully. You know, given how much we know from the trials, it's hard to believe that there isn't some sort of bias in the observational realm, but I don't have an answer.
Did you mean hypotension?
No, I don't mean hypotension. I mean cardiovascular disease, death, stroke, just whatever of the major endpoints that we looked at, blood pressure medication comes out positive. Systolic blood pressure comes out positive. But I mean, I always, whenever I'm looking at it with somebody, I say, oh, that's indication bias. And I also talked about Kenny Liu's article showing that there's an interaction between those or blood pressure level achieved in medicating and not. That Remington lecture did 7 or 8 years ago.
Yeah, and so where I feel like pharmacoepi has more value would be looking, like comparing different blood pressure medications in terms of if there's no active comparator, there are just so many other types of bias that it's hard to get a handle on it.